So some of these structural things, again, you're talking about fusions, congenital malformations, things like that. And where the issue comes into where there's more of an urgency to do the bracing and surgery and things like that, is what happens is as there's the spine, it's not just lateral flexion, it's rotation and things like that, so it distorts the rib cage. So if it gets to the point where it's bad enough where it's starting to distort the rib cage and it's affecting the function of the internal organs, then that's when it's more of a health issue. So, I mean, obviously you're going to look at the level of the shoulders, pelvis and such. But one of the things that also you want to look at that once you start noticing it, it stands out a lot more, is anything, you can notice anything with their, if you follow on this patient, where their arms are, and you can see the gap between the arm and the torso. And then we'll be talking about, as far as special tests, you want to differentiate between structural and functional. Okay? Now, if I'm standing like this and maybe something that scoliosis is due to something going on in my pelvis or something in the legs, now if I bend forward like this, which one of those do you think is going to go away, would be more likely to go away, a structural or a functional? Yeah, functional would probably go away because structural is there. Whether you're hanging from the ceiling or laying down, whatever, it's still there. Functional, if one leg's shorter than the other and it's causing it to raise like this, if you lay the patient down, the cause of that functional scoliosis is going to be diminished. Although maybe because it's from a long period of time, it's not going to completely straighten out when they lay down. But if it's structural, it's there. It's hardwired into the system. It's always going to be there. So we'll talk about Adam's position or skyline position, where you're looking to see if the hump in the spine goes away when you bend forward. Then we talk about the scapula. So again, like we had the reference point where the root of the spinal scapula is usually at what level? T3. T3. Okay. So you compare one side to the other. So I think we just already covered that slide. There's conditions where you can have an undescended scapula. So it's called Sprangel's deformity. The one scapula is going to be typically smaller than the other. It's not going to descend normally. So we're on the middle of 48. And then the muscles are also not going to develop as well. So you may have, instead of a normal muscle, you may have tight fibrous bands. So it's basically a developmental or congenital type of condition. And then we'll talk about a winged scapula. And what's the muscle that is on the inside surface of the scapula that originates right on this medial border right here? Do you remember? Okay, that's the one that's part of the rotator cuff, and that goes to what? To the humerus. But which is the one that holds it to the rib cage? The one that's on the back. It's the one that has the little slits right here? Serratus anterior, right? Because that, like, if here's the scapula, the right side, it's going from the medial part of here, because it can't attach to the front surface, that's where the subscapularis is. So it's on this medial part right here, and it's pulling it forward onto the rib cage. So if that's weak, it's going to flare out like that. Or what's called winging scapula. So here, on that side, that serratus anterior that should attach right there is not able to hold it in tight against the rib cage. So you get the winging of the scapula. And then there's the nerve that goes to that muscle is the long thoracic nerve.
So if somebody's really flexible and wing their scapula, that's different than it's like
Right.
stuck up.
Because they can do it, they can move it. But the thing that you do is a lot of times you do something like this where you have them push against here. And then you're going to need that serratus anterior to hold that in. Okay? It's one thing if you can manipulate your scapula and move it different ways, but if you can't hold it in when you're trying to, that's the serratus anterior problem. And then you compare it from one side to the other. Sometimes it can be bilateral, sometimes it can be unilateral. And then we'll get into a bunch of different chest deformities. And actually on the notes where this, on bottom of page 48, pectus carinarium, that's number 1, and then number 2 is actually, it should have been indented because that's the other name for it. So this is the pectus carinarium. So it should be like the way it is on the PowerPoint right there. So you can just, it should slide in like that. So this is just another name for that. So it's a pigeon chest, where you can see it comes to a point out there like that. Okay. And then the same thing with the excavatum. The other name for it is funnel chest.
Just congenital.
So the pigeon chest, or the carinarium, is where it sticks out, and then funnel chest, or excavatum, is where it sucks in. It's not necessarily pathologic, it's not necessarily a problem, it's just the way the body's formed. And then barrel chest. And a lot of times you're going to see this with something like emphysema, where the lungs try to expand because the alveoli are expanded, the chest is not working, even though it's, you'd expect if it's puffed up like that, that it would be able to get more air, but it's not. So gradually their chest tends to just expand to barrel out. That's more of something associated with a pathology or chronic disease rather than the other ones are just congenital. And then when you're doing observation, you also want to look at their breathing. You know, like I mentioned before, you can see their scaling. If somebody's breathing where they're just really struggling, they're using a lot of other muscles up here, versus there's other breathing patterns where some people are chest breathers, some people are abdominal breathers. And then you also want to, and anybody know what PE is? Make sure I put that on my. Right. I guess that's got left out. So that's, again, when you're doing more abdominal and thoracic type of exam, when you're checking internal organs, so breathing, what might be more part of that type of an exam. And then, like I mentioned, we're going to do range of motion as combined with thoracic and lumbar. So palpation, we'll talk about the anterior aspect of this, and then we'll talk about the sternum. And then you also want to palpate, because that's also important for point location, what they call the angle of Louis, or the sternal angle, which is right. Those legs are all twisted. It'll be right here. And then you can palpate the difference between the juncture of the ribs and the sternum, costochondral, the clavicle, the ribs and the intercostal spaces, and then abdomen. Again, this is more of orthopedics and neurology type test, but obviously part of the physical exam is the abdominal palpation. There's the two different systems of how you divide it into the quadrants, where you have the 4 quadrants, or you can have the 9 quadrants. And then just be aware of what types of internal organs are in those different quadrants.